I welcome you to a general medicine series on a lecture of acute rheumatic fever. And for this, we have our most distinguished speaker, Dr. Aditha Cibi Chakkaravarthi, sir. He's currently pursuing DM Cardio final year from the prestigious Jayadeva Institute of Cardiovascular Sciences and Research. He has completed its NEET super specialty with an All India rank 12. We are very honored to have you here, sir. Handing over the session to you.
Yeah. Yes. Hello, everyone. This is Dr. Aditha Cibi here. So today's, am I audible now? Is the video?
Yes, sir. You're audible. You're audible, sir.
Yeah.
Videos also.
Yeah, good. So as you all know, acute rheumatic fever is the cause for the most common rheumatic heart disease. We all know RHD. Day to day, we'll go to the wards. We'll see patients with mitral stenosis, mitral regurgitation, aortic stenosis, and all this will be coined as rheumatic heart disease. If you go back in time, this rheumatic heart disease was caused by something called as acute rheumatic fever in their childhood. So this topic, we'll discuss A to Z, everything about acute rheumatic fever. So the first thing I want you to have the idea when we talk about acute rheumatic fever is that think of a young boy, a 12-year-old boy. He has come to your OPD. You are sitting in your OPD. He has come to you. He has come with the complaints. He had a fever with sore throat some 2 weeks back. Now he started having pain in his knee. His right knee got swollen. There was pain. It was very tender. He was not able to catch it. And there was decrease in the range of movement. And then the patients, after 3 to 4 days, he started developing breathing difficulty. So think of it, a young boy, a 12-year-old boy, had a history of sore throat 2 weeks back, now started having joint pain, and then he started developing breathlessness. You are having a suspicion, okay, something is going on, and you are trying to auscultate him. So, or examining him. You are finding a soft S1 and a pansystolic murmur. When you auscultate for the mitral area at the apex, you are developing a pansystolic murmur. Now you get intrigued. Yes, and you see his joint. You are seeing the joint is significantly swollen and it is painful. And when you touch it, he is wincing in pain. So you think, okay, this could be rheumatic fever. And then you start investigating him. You send blood investigations from your OPD or advise ESR, C-reactive protein, ASA, and you found that everything is raised. ESR is 60, CRP is 4, ASO is so much, 600. And now you start suspecting some cardiac involvement is there. So you start investigating his heart. You get your ECG, you find a first-degree heart block. We'll come to you what it is. And then you do a chest X-ray, you find his heart to be enlarged. And then you advise and suggesting for an echo, and you start finding the valve regurgitation. The mitral valve is regurgitating, and you are getting a mitral regurgitation, and the mitral leaflet appears thickened. Now you can confidently say this is a case of acute rheumatic fever. Now you have diagnosed. Now, how do you manage that guy? You start, first thing, you give him an antibiotic, a shot of benzathine penicillin. And then, and you advise him bed rest for around 4 weeks, and start him on aspirin. This the drug of choice here. You start him on aspirin for 4 divided doses, and then you give some diuretics for his breathlessness, and then you follow him up after a week. In a week, you find that his joint pain has come down significantly, and the echo follow on after 2 weeks. You start developing mitral regurgitation is persistent, and then you put the patient on Panadol prophylaxis. That is 1.2 million units. So what we saw here, a patient presenting with acute fever with sore throat. Then 2 weeks later, he started developing a joint pain. And then 4 or 5 days later, he started developing breathlessness. You auscultate a murmur, and you are thinking of ARF. You are sending investigation, CBC, ESR, CRP, all are raised. ASO, the typical test which we do, ASO is raised. And then you ECG showing first-degree heart block, X-ray showing cardiomegaly. You do an echo, you are finding MR. Then you make a diagnosis of ARF, put him on bed rest, aspirin, and then you give some diuretics for his congestion. He feels okay. He comes back in the follow-up. You are having significant regurgitation in the follow-up. Then you put him on secondary prophylaxis. So what we saw here in this 2 minutes is the overview of the acute rheumatic fever patient. Now we'll go step by step. So what is this acute rheumatic fever and how common is it? See, as we know, it is variable in according in different areas. You take any developing countries like India, the South American population, Southeast Asian population, where the basic development is not that good, or in developing countries, this ARF is seen in high prevalence. Let's say it's 1 to 2 per thousand is the prevalence of rheumatic heart disease. See, remember, rheumatic heart disease is an not what we are talking about. Rheumatic or disease is the end result of acute rheumatic fever. Now, acute rheumatic fever, it's little rarer than an acute rheumatic heart disease. It should be 1 to 2 per 1 lakh population. Almost 1 in 10. This is the AR of prevalence. See, in a developing country, if you go to where the incidence is very high, these numbers can be up to 10 to 20 per 1 lakh population in developing countries. In a developed country, it will be less than 1 per 1 lakh population. So it varies from the different geographies. So the other thing now we have to know is that we saw the patient started with having a sore throat. See, one thing you have to understand is that the sore throat which a child develops can be bacterial or it can be viral. Suppose there are 100 patients who are developing sore throat, around 80% will be viral and only 20% will be bacterial. This bacterial, which is because of group A beta hemolytic streptococci, the streptococci, this is our pathogen. This is our problem. These are the pharyngitis which go on to develop acute rheumatic fever. In this, if you consider how much person develops rheumatic heart disease or ARF, it should be 0.3%. If it is in a common areas, and if it is epidemic, you get 3%. In an epidemic area, you find it as 3%. The only if the 20%, only 3% will develop acute rheumatic fever. Of that, only 40 to 50%. Of that, only 40 to 40% will develop rheumatic heart disease with carditis. So this is what you have to know. You have 100 patients with pharyngitis, 80 will be viral, 20 will be bacterial. Of the 20 who develop bacterial pharyngitis, only 0.3 to 3% will develop acute rheumatic fever. Of that, only 50 to 60% will develop carditis. And of that, very few only will go on to develop RHDs. Now, what is the bacterial? Now you have to know what is a bacterial pharyngitis and how is a viral pharyngitis. We diagnose it using something called a Centas criteria. So basically, what is a bacterial pharyngitis? So any pharyngitis we know will have fever will be there. It will be common in both. The sore throat, this is the classical finding. This is seen with bacterial pharyngitis, not in the viral pharyngitis. And then you will have tonsillopharyngeal erythema. Tonsillopharyngeal erythema plus exudation. Both will be there. Tonsillopharyngeal erythema and exudation, both will be there. Because what does it mean? If you open the mouth and ask him to say, let his tongue out, you can find redness on the posterior pharyngeal wall, and also you can find a lot of white patches on the posterior pharyngeal wall. This is classically seen with bacterial pharyngitis, and you can also have enlarged cervical lymph nodes. Anti-cervical lymph nodes will be enlarged. This way, you will know which is the bacterial pharyngitis. And viral pharyngitis, if you think, there will be a lot of running nose, like basic URI. Running nose will be more here, and postnasal drip will also be more commonly seen with viral pharyngitis. So any patient, fever, sore throat, tonsillopharyngeal erythema, exudation, and under cervical lymph nodes, think of bacterial. If he has running nose and postnasal drip and those things, think of it as viral pharyngitis. So I have spoken to you at what happens from pharyngitis to ARF. So what is the pathophysiology? How can a pharyngitis end up in acute rheumatic fever? So here the problem is group A beta hemolytic streptococcus. They have caused a pharyngitis. So how a pharyngeal infection can cause heart problem and other problems? See, that is because of a concept, or once a bacteria enters the pharynx, our body will try to hit the bacteria. Both your T cells and B cells, both will try to hit the bacteria and try to destroy it. But the problem is the bacterial antigens, predominantly the M proteins, they resemble a lot of human proteins. Like in the heart valves can be there. They resemble few proteins. The brains will have few proteins, and the joints will have few proteins, and the skin and subcutaneous tissues will have few proteins. These human proteins will mimic the group A streptococcal antigens, that bacterial proteins. So when the body is trying to hit the bacteria, unfortunately, because of an autoimmune or inflammatory process, it starts hitting our own body antigen, and then we develop all the problems. Here, the basic pathology is that molecular mimicry, because the bacterial antigens mimic the human body antigens. Now, who are at high risk of acute rheumatic fever? As I said earlier, it's the developing country. Think of India. It's the only developing countries are at high risk of developing acute rheumatic fever. The basic age group which we say is 5 to 15 years. If it is malnutrition, overcrowding, poor sanitations, poor access to healthcare, and then improper treatment of the pharyngitis. Pharyngitis treatment is not good. So these are the group of, these are a few risk factors which increase the prevalence of acute rheumatic fever. So overpopulation and overcrowding is one of the important risk factors, and it is more common in 5 to 15 years of age group. That is the age group when you have this maximum incidence, and it is more common in winter and spring seasons. And there is also some genetic predisposition also. That is also there for acute rheumatic fever. So any young boy who is coming from a not so good background, who is having overcrowding and has that sore throat and untreated or not properly has gone for any medical checkups, he is at higher risk of developing ARF. Okay, now this is how we have explained how does a sore throat cause a heart and skin joint problem that we have explained. You can see that the bacteria entering into the pharyngeal wall enters into the body. It is recognized by the T cells and B cells, by the antigen presenting cells. They start releasing cytokines and antibodies. This will take 2 weeks. A lot of antibodies and B cells and the activated T cells, they will go and damage the heart, the brain, the joint, and the skin, accounting for all the manifestations of acute rheumatic fever. Heart they damage and they cause pancreatitis, and brain they damage and cause something called as chorea. We'll go into it in the further people. And joint they cause something called as arthritis, joint pains and swelling. You remember our case. Our case had pancreatitis and arthritis. And you can also have erythema marginatum and subcutaneous nodules. So all these findings will be there because of this immune process. So what are the cross-reacting proteins? You have to know this is the important antigen, the M protein. It is present in the cell wall of the bacteria. This M protein will share some antigens which look similar to our human valves. Human valves in the form of, let's say, myosin, tropomyosin. All these things will be most commonly cross-linked here. Okay. And then the joints, hyaluronic acid. This hyaluronic acid of the bacteria will be close to what is called as human synovial fluid, and this causes the arthritis. Synovial fluid is something that is present in the joint. Because of the bacterial hyaluronic acid is similar to our synovial fluid, we have cross-link here and we have the joint problems. And then the carbohydrate A antigen, especially against the brains, especially in the basal ganglia region, they cross-react and cause the chorea. So these are the cross-reacting antigens between the bacterial and human tissue responsible for the corresponding manifestations. Now, coming to the all-important Jones criteria. So there is something called as, am I audible, right? Parthiban?
Yes, sir. Yes, sir.
Yeah, you're good. So what the major criteria, think of the mnemonic of space. So first one is the S stands for the subcutaneous nodules. P stands for pancreatitis. You have to know all the area of heart, the endocardium, myocardium, and the pericardium. All three will be involved. This is called pancreatitis. Third one will be the arthritis. And fourth one will be the chorea. And then E will be the erythema marginatum. So synonym subcutaneous nodules, polyarthritis, and then pancreatitis, chorea, erythema marginatum. These are the major criteria. And what's the minor criteria? You have fever, polyarthralgia. There is a difference between arthritis and arthralgia is that arthralgia is just pain in a joint. Arthritis means you will have signs of inflammation. There is redness, there is tenderness, there is decrease in range of movement. If there is polyarthritis, you consider it as major criteria. If there is polyarthralgia, you consider it as minor criteria. The other one will be fever, raised ESR, raised CRP, and prolonged PR interval. Remember in our case had fever was there, ESR was raised, CRP was raised, PR prolongation was there, and then he had arthritis and carditis. Okay. Now, there are two tablets. If you can see here, there are one is on the left and one is on the right. There is something called as low risk population and something called as high risk population. And how do you define what is low risk and what is high risk? That is where you come to our the prevalence. This is based on the prevalence. Suppose think of India. In India, there is definitely high risk of acute rheumatic fever. So the incidence of RHR is definitely more than 1 per 1,000 and ARF is around 2 per 1 lakh population. This is school-going children. If there are 1 lakh school-going children and if more than 2 of them have acute rheumatic fever, then it is a high-risk population. If there is 1 lakh school-going children and less than 2 have acute rheumatic fever, then it comes to be a low-risk population. Then if you go for an established rheumatic heart disease, if it is more than 1, it is high risk. And if it is less than 1, it is low risk. So based on America or European countries, the commander will be low risk and all the developing countries are high risk. So the difference between low and high risk is that in high risk population, all the cutoffs are little lower. Suppose in India, if a person, if an American child to call it as acute rheumatic fever, he should have multiple arthritis. They should have multiple joints should be involved and polyarthritis should be there. In India, it may be polyarthritis, it can be monoarthritis, or it can be polyarthralgia. So it can just be joint pain and or it can be joint inflammation in India, whereas in American population, it has to be significant arthritis involving multiple joints. In India, one joint pain is enough. That is one difference. And the other difference which we have is that then the cutoff value. So fever in India has to be more than 38. Even that is like you consider it as minor criteria. In an America or low risk population, it should be more than 38.5. And ESR more than 30 is significant in India. And ESR more than 60 is significant in America. So a higher cutoff, higher value reads. And if you go here, it should be polyarthritis in US or developed countries. And low risk population, it is polyarthritis, monoarthritis, or polyarthralgia. This is the major criteria. And if you go to the minor criteria, polyarthralgia is the minor criteria in low risk, and monoarthralgia is the minor criteria in high risk populations. So simply summing up, there is 5 major criteria. That is, you can have subcutaneous nodules, pancreatitis, arthritis, chorea, and erythema marginatum. If it is low risk, think of India. That is what we want more. So low risk, you have in India there is a high risk. You have lower cutoffs. So ESR more than 30, 30 is a cutoff, and fever more than 38 degrees centigrade. It is important. And arthritis criteria, it is monoarthritis, polyarthritis, and polyarthralgia. They are significant in Indian population. Okay. Now we will go for arthritis. So as I said, arthritis. What is arthritis? Arthritis means there is pain of the joint, there is swelling, there is redness, and there is tenderness of the joint, and there is a decreased range of movement of the joint. So this is what is called as arthritis, and arthralgia is only pain. Only pain is there, you can consider it as arthralgia. So what is the difference? What is the unique point of this arthritis in comparison to other things? So first thing you have to know is rheumatic response to aspirin. Aspirin, as we all know, is something which we give to reduce the pain. Compared to other arthritis, acute rheumatic fever, arthritis, if you start the patient on aspirin, the pain comes down immediately within 48 hours. There is dramatic response. If you don't have such a dramatic response, you can virtually rule out acute rheumatic fever. So any arthritis, you can call it as like aspirin sensitive arthritis. Any arthritis, start on aspirin, good response, think of ARF. No response, more than 48 hours, think of alternate diagnosis. And second one is the unique feature is in the migratory. So it keeps moving from one joint to another. So day one, you have knee pain, swelling and redness, and then it comes on in 1 or 2 days. And then third day, it goes and involves the ankle. And then it goes and involves the elbow. So it keeps jumping from one joint to another joint. So it is migratory and fleeting. The joint, when it's involved, is most likely there is no residual deficit. Once it hits a joint and moves to other joint, there is no residual deficit in that joint that is involved. So it is fleeting. And then you have to know the other important issue with this arthritis is that it can involve the large joints like knee. Knee is one of the most commonly involved, and then you can involve the ankle, and then you can involve the elbow or the wrist. A close mimic to this arthritis is something called as PSRA. It is post-streptococcal reactive arthritis. Just 2 points. They involve the midline joint. So midline joints in the sense, this acute rheumatic fever will involve the periphery joints. PSRA will involve the axial joints. So what are the axial joints? You can have the vertebral joints involvement. So this is classical in PSRA. And in acute rheumatic fever, as I said, there will be 2 weeks gap between the onset of sore throat to the development of arthritis. Here it is very fast. Within 1 week, you will have this onset of symptoms. So summing up, any patient with knee pain, swelling, tenderness, redness, which is migratory. Day one, it is in the knee, and day two is going to the hip, and which is asymmetrical. It is not both the right and left, both are not involved. Only one side is involved. So asymmetrical, migratory, fleeting, large joint arthritis with dramatic response to aspirin. Think of acute rheumatic fever arthritis. And then coming to the most important point. See, carditis is most common in children, and arthritis is more common in adult. C for C and A for A. So carditis, what is that carditis you have in ARF? It is a pancarditis. So what is this pancarditis, which I mentioned earlier? You have 3 areas of the heart. The outer layer is called as the pericardium. So there is inflammation of the pericardium, and then the myocardium. There is inflammation of the myocardium, and then you have the endocardium, where also inflammation is there. The endocardial involvement. This is the classical finding seen in acute rheumatic fever. Any carditis without endocardial involvement, don't think of ARF, because this is classically seen in ARF. So by endocarditis, what will happen? It is predominantly valvular involvement. So valves, what can happen? Even the most commonly involved valves in acute rheumatic fever is the mitral valve. Around 75% involvement is seen in mitral valve. So this is because there is significant pressure difference between the left atrium and left ventricle. If you see that the mitral valve is consistently exposed to high pressure, so mitral valve is more commonly involved. And then the tricuspid valve, and then the aortic valve is again most common. And then the tricuspid valve, and the least common one will be the pulmonary valve. It is the least common to involve. So what form of involvement will be there in mitral valves? So as we all know, in RHD, we all think it is MS. In acute rheumatic fever, it is always MR. So mitral regurgitation is the most common manifestation of acute rheumatic fever. And we all know mitral regurgitation will produce a pansystolic murmur. So what do you mean in pansystolic murmur? You have tup. The first one is S, and second one is S1, and second is S2. If you have a murmur that starts from S1 and goes all the way to S2, that full murmur is there, that you have to think of pansystolic murmur, and this will be better heard in the apex. This is the mitral regurgitation. And then you have what is called as Carey-Coombs murmur. Carey-Coombs murmur, what we say it as the mid-diastolic murmur. This is because of the mitral valvulitis, mitral valve inflammation. So how does mid-diastolic murmur happen? You have S1, you have S2, you have the next S1. So this is the systole, and this is the next part is the diastole. In the middle of the diastole, you will start having murmur. So this is mid-diastolic murmur. So you have that way you will have one S1, S2, and then you have a diastolic murmur. This is similar to our MS murmur, where again it's a mid-diastolic murmur. And then you can have the AR murmur. AR murmur, which we call it as the early diastolic murmur. So early diastolic murmur, S1 is there, and then S2 is there, and then again the S1. And it is the early part of the diastole only, you will have the murmur will be decrescendo. Here you see it is mid-diastolic. In MDM, murmur is the mid-diastolic. Here you have the early diastolic murmur. So you have a pansystolic murmur, you have a mid-diastolic murmur, you have an early diastolic murmur. When you find all these findings, and because of the M1, S1 is soft because of the MR. When you have all these findings, you have to think in terms of endocarditis or valvulitis. So the other findings in acute rheumatic fever will be the pericarditis. So who will be a patient with pericarditis? Any patient with complaints of exertional, any patient complaints of chest pain which is increasing with respiration, increase in inspiration, or it is changing by increase in position. With the patient will have a pericardial rub. When you auscultate, you will have a superficial scratchy sound. The pericardial rub will be there, and then if you do an echo or something, you will find a pericardial effusion in these patients. Pericardial effusion means there is the formation of fluid, a liquid is seen in the pericardial layer. Pericardial effusions will be there, and STT changes will be there. ST elevation, diffuse global ST elevations. That is commonly seen with pericarditis. And then what you have is myocarditis. So outer layer is pericarditis, middle layer is myocarditis, and myocarditis, this is where you will have, there is significant tachycardia. Tachycardia out of proportion. And tachycardia means there is increase in heart rate. The patient will have an heart rate of 130, 140 beats per minute. Here also the S1 will be soft, and then they can have S3 will be there. There can be, that is what is gallop rhythm they say, that will be there. But one unique feature of this acute rheumatic fever is that there is no LV dysfunction. Other myocarditis will have LV dysfunction. Here there is no LV dysfunction. And one more feature of this pericarditis is that there is no tamponade. So what do you mean by tamponade? This means there is accumulation of fluid within the pericardial cavity. If it is there in a significant amount, it can compress all the chambers and cause a problem called tamponade. That is the most feared complications of pericarditis that you don't have here. Yeah, and myocarditis also, there is no LV dysfunction. The EF is most probably maintained in these patients. And then endocarditis in the form of MR, AR, and MDM. So carditis means the child, this is very common, 70% involvement will be there. The child will have symptoms like shortness of breath. You remember our case. The person has shortness of breath because of the MR. There can be palpitations because of arrhythmias, and then the patients can have fatigue. So these are the symptoms you can have because of carditis, and that involvement is all three layers, which I said earlier. Now we have seen arthritis and carditis. The next important thing is chorea. So this is called a Saint Vitus dance. So what is chorea? See, the difference between arthritis and carditis is an early manifestation. That means you have a sore throat. Within 2 weeks or 4 weeks, you get arthritis and carditis. Chorea, first thing you have to know, it is a late manifestation. It occurs up to 1 to 3 months after the incidence of acute rheumatic fever. And what are the specific findings in serious chorea? See, the patient will have rapid, involuntary. It won't be under his control. And then purposeless, and then it will involve the distal. There will be involuntary movement of the fingers, of the hands, of the legs, and there will be a lot of grimacing of the face. They will make a lot of movements in the face. So there will be, you can see in the picture also, there is involuntary movements in hands, in the legs, and they keep making, and you can see it is making trying grimaces of the face. So these things will be very commonly seen in acute rheumatic chorea. So why does chorea happen? As I said earlier, it is because of the cross reaction of the group-based streptococcus to the basal ganglia. So basal ganglia is one that is hit here. And then because the basal ganglia is hit here, you can have all this involuntary movements. But there will be no sensory involvement. There will be no motor involvement. And another point you have to know here about chorea is that these patients will have few findings. First one is the milk-maid grip. So what do you mean by milk-maid grip? If you ask the patient to hold your finger, they won't be able to hold it too tight. They will be giving repeated squeezes. They won't be able to hold it tightly. So that is what is called as milkmaid's grip. And second thing is called as jack-in-the-box tongue. So if you ask the patient to put their tongue out, they will not be able to maintain the position out. It will keep moving in and out. Involuntary, it will keep moving and out. That is what is called as jack-in-a-box tongue. And then the speech will be jerky or staccato speech. That will be very commonly seen in these chorea patients. And basically, it is a triad. So chorea, emotional lability. So they are they will be emotionally weak, and emotionally they'll keep moving here and there. There will be behavior disturbance and hypotonia. So this is the triad of the symptoms that is commonly seen in patients with aromatic chorea. And we have to know it is more commonly seen in female populations. It is a late manifestation, seen 2 to 3 months later after the year of incidence, and the patients can have a lot of other issues. So then the other going to the next manifestation will be erythema marginatum. This is the image that is showing erythema marginatum. So you can see there is centrally there is nothing is there. So central clearing will be there, and then be raised. So it will be raised, bright pink, macular lesions. It is important to know it won't be pain, it will be painless. It won't be there will be no itching. It will be non-pruritic, painless, non-pruritic, raised bright pink macules. And they are actually quite rare in Indian population owing to the dark complexion. They are more commonly seen in Western population. They have this classical central clearing concept, and the peripheries are like serpiginous or annular. You can see it just keeps going. There is serpiginous borders are there, and they predominantly involve the thorax, the chest, and the proximal part of the limbs. They never occur on the face. And this is little rare manifestations of, we see less than 10% of the patients will have erythema marginatum. This will be exaggerated after you taking a hot bath or something. After hot water, it can be increased. This thing will come more. So now going next to the what is called a subcutaneous nodule. So it is important to know subcutaneous nodule because you can see in the picture, this is the subcutaneous nodules. And you can see here, it is a subcutaneous nodule. You can see the head. So it occurs over the tendons. If you see, it is over the elbows, over the knuckles, and over the foot. So it is possibly, it is pinhead to almond sized. Pinhead to almond sized. Small nodules, it is painless. The skin is actually freely mobile. This painless nodules, it indicates what is the clinical significance. If you have a patient with acute rheumatic fever and subcutaneous nodules, think it is a severe carditis. There is severe heart involvement is definitely there. So any patient you find acute rheumatic fever nodules, think it of severe carditis. And there are a lot of conditions can have subcutaneous nodules. So that is important to rule out all the other conditions also. So we have seen all the 5 major manifestations. First is the arthritis. Arthritis important is that is migratory. One day involve one joint, the other day goes to another joint. It is asymmetrical. It is fleeting. It is very painful with good response to aspirin. And then the carditis, shortness of breath, fatigue, or palpitation because of MR, AR, or MR valvulitis, or can myocarditis or pericarditis. Then you have 2 skin manifestations: the nodules and the subcutaneous nodules and the erythema marginatum, and 1 brain manifestation, the form of chorea, involuntary movements. So this is the common 5 major clinical features of acute rheumatic fever. Okay. Now we have seen a patient with acute rheumatic fever who has got all these manifestations. You have seen now what will you go at? How will you go about? So first you do a CBC, very common investigation, where you can find the WBC count can be raised because of the antecedent infection or systemic inflammation. WBC counts can be raised. And then you do the via markers, ESR and CRP. And the ESR will be significantly raised. Remember the number. 30 in case of India and 60 in case of America. The ESR will be significantly raised. CRP will be raised more than 4 milligram per deciliter. And then you do the classical test, the ASO of the ADB. ASO means anti-streptolysin O, and ADB is anti-DNA ribosome enzymes. So ASO, if it is more than 250 TOD units in adults or more than 333 TOD units in children, it is going to be significant. ASO is more than 250 TOD units in adults. So any patient with raised ESR, raised CRP, raised ASO, raised ADP, then you have to think in terms of acute rheumatic fever. Then you do the ECG. And ECG, you find what it was first degree heart block. And this can be taken up as an evidence of carditis if you don't have major criteria. So this is the P and you have the QRS. If the gap between the P and the QRS is more than 5 small box, or if it is more than 200 milliseconds, then you have to think in terms of first degree heart block. If that is there in ECG, that is also a soft marker. And then you have to do investigation like chest X-ray. Chest X-ray will reveal cardiomegaly. Because of what I said, because of the MR and the AR, there will be LV type of cardiomegaly will be there. The heart size will increase. And then you do the echo. And echo, you can find some features like thickening of the mitral valves. That is classically seen in ARF or acute rheumatic fever or HD. AML will be thickened, and then you will have MR lesions, you will have AR findings, and you will have RMS findings. Anything you can all pick this up in echocardiogram. So there are three basic things which we have to know. If there should be an evidence of streptococcal infections, that is there to diagnose in Jones criteria. So what do you mean evidence of streptococcal infection? See, the patient, which I told it as sore throat, history should be that. That is there, it is suggestive. But you need evidence, a lab evidence. That is given by a positive culture, throat culture. Like the COVID time, they took throat swab cultures. If they are positive, then that is a evidence of streptococcal infection. The other thing which you can do is that this ASO and ADP, they are also an evidence of streptococcal infection. The other thing you can do is that RADT. It is the rapid antigen detection test. And what do we mean by they detect the antigen of the streptococcus in a very quick manner. So in the background of RADT positive or throat swab positive or raised ASO or ADP, if the patient is having joint pain or chorea or carditis or erythema marginal or subcutaneous nodules, then you have to diagnose acute rheumatic fever. Now, coming to the last part, during the management, you have diagnosed, your patient has come with all these findings, you have diagnosed the acute rheumatic fever, then what will you do now? You have to advise bed rest. Then the severity depends upon the severity of underlying infection. 2 weeks if it's just mild joint pain. If there is carditis, you wait up to 4 to 6 weeks of bed rest or avoiding physical activity. That is important. Then antibiotics for primary prophylaxis and secondary prophylaxis. Primary prophylaxis means it is the treatment of that sore throat or clearing that bacteria. Even if the patient doesn't have any symptom, in order to clear the existing bacteria in the pharyngeal thing, you give antibiotics, and that is called as primary prophylaxis. And secondary prophylaxis means the patient keeps on receiving antibiotics for once in every 3 weeks or once in every 2 weeks till a particular period of time to prevent further streptococcal sore throat and further molecular class mimicry and further heart or brain damage. To prevent that, we give antibiotics on a frequent period of time. That is called as secondary prophylaxis. And then you give anti-inflammatory, because it's basically an inflammatory disease. To control the disease, you give the anti-inflammatory treatment, and surgery is rarely required if there is severe mitral regurgitation. If there is severe mitral regurgitation that is not being corrected by any heart failure medications, then you have to consider surgeries, and chorea management is also be discussed. So first thing is the anti-inflammatory treatment. So anti-inflammatory treatment, as I said, if the patient has just joint pain, only arthritis, then you got mild carditis, aspirin would suffice. And dose of aspirin is 80 to 100 milligram per kilogram per day in 4 divided doses. Remember, the aspirin which we use for heart attack or any sort of anti-ischemic effect is low dose. 75 mg is what we use, or 150 mg. This is what we use for low dose aspirin is for antiplatelet action. Here we want anti-inflammatory action. This is like 80 mg per kg. So it's like you just remember, you calculate the weight of the patient and then you calculate his daily dose and you divide split into the 4. So 625 280 or 4 times a day, you give like that. And then what is the duration of the treatment? You have to give it for a period of 12 weeks. 6 weeks you give the full dose, and then you taper over next to 6 weeks. This can be given. If the also what you have to note for if the patient is on aspirin, because it's a gastroirritant, some GI disturbance will definitely be there. And you also have to look for worsening of LFT to think of Ray's syndrome. In any URA in starting aspirin and if the LFT raises, you have to think of Ray's syndrome. Or the third thing which you have to think in is synchronism. Synchronism means the aspirin toxicity manifested like tinnitus, hearing and sensation, the ear, vomiting, those things will be there. If there is aspirin intolerance, then you can do naproxen. It is given a dose of 10 to 20 mg per kg. It is less irritant, and few trials have shown that naproxen is as beneficial or even better than aspirin. Few trials have been coming up. So if aspirin is intolerant, you can definitely try naproxen. Just a minute. Okay. And then if the patient is having severe carditis, or if the patient is having refractory carditis, that's when you start considering aspirin. If you have give aspirin for 3 days and 4 days are not responding, then you have to consider steroids. Methylprednisolone, prednisone, oral prednisone is first we tried. It is given at a dose of 2 mg per kg per day. You give it for a period of 3 weeks, and then you taper it over alternate days, and then you total period of 12 weeks should be given. While tapering, you should start aspirin for these patients. And then if that is not responding, IV methylprednisolone can be tried. So anti-inflammatory, if it is just joint pain, try aspirin or naproxen. If the patient is having severe heart failure, then consider steroids for that. During tapering, start aspirin, even if you give steroids also. So then comes to the primary prophylaxis. This is basically the treating for the sore throat or treating, giving an injection to clear the existing bacteria. It can be given up to 9 days. Up to 9 days, there is the giving penicillin is going to be beneficial. So what are the drugs? What are the antibiotics which you can give? So first antibiotic which you can give is Medusane penicillin, single dose. Weight base. If the patient is more than 27 kg, you use the full dose 1.2 million. If the patient is less than 27 kg, then use 6 lakh units. Single dose will clear off bacteria. So if the patient, if you don't want to go for injection, you want to go oral medication, then you can give penicillin or the Pentix tablet. You give it as 250 milligram BD for 10 days. If that is not clearing, then you have to go for amoxicillin. Again, 50 mg per kg. It can be 500 mg can be given BD for 10 days. Or if there is some sort of penicillin allergy, then you can go for other drugs like cephalexin, ceftriaxone. If there are azithromycin, erythromycin, clarithromycin, all these drugs can be given in the primary prophylaxis if you have penicillin allergy. If best one will be the injection benzathine penicillin, that will give the best possible result. If that is not given, then try oral penicillin. Or if he is having any allergy, because penicillin is one drug where this allergy or anaphylaxis is very common. If that is there, then you have to go for other drugs like amoxicillin or cephalexin, ceftriaxone, azithromycin, erythromycin, or clarithromycin. And then you have to go for secondary prophylaxis. What do I mean by secondary prophylaxis? So a patient has developed acute rheumatic fever, and then you follow him up, and to prevent further episodes of acute rheumatic fever, you give antibiotics. So antibiotic you be given once in 3 weeks, once in 2 weeks, based on the profile, and for a period of time to prevent further sore throat or further progression of infections. That can be classified into 3 types. The first one is a patient having ARF, only arthritis, no carditis. That guy, you have to give him 5 years or until 21 years of age, whichever is longer. Suppose he is 12 years old and he has developed, in our case, we got acute rheumatic fever. With carditis, if there is no carditis, you can give up to 21 years of age or 5 years, whichever is longer from that point. If in that case, you have to give benzathine penicillin. And this is the injection, 1.2 million units, IV once in every 4 weeks. Again, if it is less than 27 kg, you can use 6 lakhs. So 4 weeks or 3 weeks or 2 weeks, basically, the shorter the number of weeks, better the result is there. So we use 3 weeks very commonly in most of the Indian setups. So once in 3 weeks, the patient should receive 1 injection penicillin. They will come to the hospital, get the injection, and go back. And that is there. If there is carditis, mild carditis is there, but no residual heart disease, no MS, no MR, no AS or AR, ARF with carditis, but completely healed. That patient should be 10 years or 21 years, whichever is longer. The same dose, 1.2 million units, once in 3 weeks we can use. Coming to the third group, the acute rheumatic fever with severe carditis or residual heart disease. If the patient is having severe carditis or the patient is having MS, MR, AS, AR, existing valvular heart disease, in that time you have to give the penicillin injection once in every 3 weeks. It can be till 40 years of age. The WHO says lifelong, but we prefer up to 40 to 45 years of age, because after that, the incidence of AR tends to come down dramatically. So till that point, you should give penicillin, benzathine penicillin. So what are if the patient doesn't want to get an IM injection, because penicillin is a very painful injection, and it is given deep IM. It is given deep IM, and so there will be significant pain at the site when you give penicillin. So people won't prefer penicillin. In those cases, you can give oral tablets. So oral penicillin like 250 milligram BD can be given, Pentix. If there is penicillin allergy, then sulfadiazine. See, remember, sulfadiazine was not there in primary prophylaxis. It can be given for secondary prophylaxis. 500 mg BD can be given. If there is allergy to that, then erythromycin can be given. And then coming to the management of heart failure. As I said earlier, heart failure is very common in patients with acute rheumatic fever. If there is severe carditis, then the patient will be in pulmonary edema desaturation. So put the patient on oxygen. If required, if the patient is not maintaining saturation with oxygen, put the patient on non-invasive ventilation. means BiPAP or CPAP to give positive pressure ventilation to clear of the desaturation. If the patient's very bad, you will have to intubate. Endotracheal intubation may be required. For this is for respiratory failure management. Then for to prevent the pulmonary edema, you will have to give drugs like diuretics like Lasix, means furosemide. Furosemide should be given. Diuretics should be given to reduce the congestions, and then few drugs like inotropes. If there is heart pumping is too bad, then inotropes may be required, or patients may require other drugs like digoxins. To reduce the afterload, we can use drugs like AC inhibitors. These are all drugs that are used for treatment of heart failure. So basically, heart failure means the patient is in breathless dyspnea, apnea, PND, or sudden onset severe breathlessness because of the FEMR. We put the patient on oxygen. If there is not saturation is not maintained, put the patient on NAV. Still not maintained, try to intubate him. And then you have to reduce the congestion. So you give injections like diuretic, like Lasix, that will reduce the pulmonary congestion. If the heart pumping is bad, you give injections like inotropes, like noradrenaline, dopamine, dobutamine. Those things will increase the force of contraction, maintain the cardiac output. If that is not working, digoxin can be tried or AC inhibitors can be tried. So coming to the management of chorea. So again, chorea is actually these are mostly self-limiting diseases, except for heart. Everything else will be hit and run. You will have arthritis, it will be cured. You have this, you have cured. Only heart, it can lead to long-term damagement. But still, if there is if the symptoms are severe, you advise bed rest, you give them reassurance, you avoid triggers. See, this chorea of movements will disappear during sleep. But if the patient is anxious or tense, the movements tend to be high. So give them reassurance and give them that. And the drug of choice will be valproate or carbamazepine can be given for the treatment. If that is not responding to that, haloperidol or risperidone can be given. If it is very refractory cases, then you have to consider IVIG or plasmapheresis. So this sums up my discussion on acute rheumatic fever. So now at this point, you have seen like what I have explained. Now you just pause this video, look into the questions, and try to answer those questions. Now think, what is acute rheumatic fever? And what is the pathogenesis? How does a sore throat causes heart, brain, and joint problems? And what is the major criteria which we have discussed? What is the minor criteria? What is the high risk population? What is the low risk populations? What are the investigations to do? And how do you treat the patients? Pause it and try to recollect. Something will you will recollect something, you will won't be recollect something and leave it, but try to pull it maximum and then go back and start seeing the video again. Whatever is you missed out will be explained. So basically, any young boy, 10 to 15 years old boy who is coming sore throat, and then 2 weeks later, if he has joint pain, followed by arthritis, like, and followed by breathlessness or palpitations, and he has some skin nodules or rashes or some involuntary movements, you have to think in terms of acute rheumatic fever. Though the ESR, CRP will be raised, ASO will be raised, and ECG shows PR interval. Echo, get an echo done, rule out any MR or anything is there. If there is chorea or something, do an MRI. You can see that basal ganglia, there can be lesions will be there. Or then you can diagnose it and start managing with, give them aspirin. If there is severe, give them steroids. Or then if required, do heart failure medications and specific management for chorea. That is also explained. That also you have to give. So this concludes my talk on acute rheumatic fever. If you have any doubts regarding any aspect, do definitely ask me, or you can post in the comments. We'll definitely reply.
Thank you, sir. Thank you so much. It was really a wonderful session, not just for from the point of undergraduate exam, but it extends till the NEET PG. Every single point has been covered in this short time. Thank you so much, sir, for joining with us. And if you guys have any doubt in the session, even after the session, if you are having any doubt, kindly put it in the chat box, and sir as well as myself will be glad to answer it. Sir, I will take forward the questions to sir, and I'll make sure that it gets answered to you. Thank you so much, guys. So let's meet in the other session. Hope you guys are going to have your final year exam soon. All the final years, those who have joined through here, we are also planning for an exciting uh, complete package of revision course, which will be announced in the meanwhile. So until then, stay focused and try to prepare for your exams, which is tentatively planned in the March month. So try to keep focus and try to read it. Thank you, sir. Thank you once again. With this, we will be like ending the stream. Yes, sir. Thank you, sir. End stream
Every
end. So, sir